Is it possible that we could maybe try to deal with resistance before it happens rather than expecting it to happen and doing everything we know that will cause resistance? Breast cancer, lung cancer, colon cancer, pancreatic cancer have not been cured despite decades of large randomized controlled trials. We can have two people with the identical mutations within their cancer, and they may respond differently to the same treatment because there are so many other variables that come into play and are active in a cancer situation. We need to know in real time whether this treatment with its toxicities is actually doing anything beneficial. We will have patches on the arm that are like continuous glucose monitors, that will be continuous tumor monitors. I haven't met anyone who doesn't like to feel like after a terrible diagnosis, like a cancer diagnosis where your life is threatened, having some more control is generally something that people thrive with and look forward to. I wake up every day thinking I'm so lucky that I get to be a doctor.
What if everything we know about late-stage cancer treatment is backwards? While standard oncology accepts treatment resistance as inevitable for metastatic disease, something to manage until the disease kills you, Dr. Dawn Lemanne is proving it can be reversed. Dr. Lemanne, it is such a pleasure to have you on Kicking Cancer's Ass.
Thank you for having me.
Let's dive in. You work with patients who've often been told their metastatic cancer is incurable. When someone walks into your office carrying that prognosis, how do you shift the conversation from managing inevitable resistance to let's see if we can reverse what everyone says is irreversible?
I think oncologists don't ask the question, why can't we reverse treatment resistance? I have been trying to think about that question, and that's how I ran into the idea of cancer as an evolutionary process. And evolution can sometimes be steered, not always, but sometimes it can be. And where we've learned about that is from agriculture, where it's been known for decades and been used for decades. The idea that you cannot apply, for instance, a pesticide or an insecticide at maximum dose constantly and not have to deal with the development of resistance. Is it possible that we could maybe try to deal with resistance before it happens rather than expecting it to happen and doing everything we know that will cause resistance? And maybe we should change that conversation. Everybody has to have a different conversation because they come to me at different points in the resistance development spectrum.
I would think for someone who's been told they have stage 4 that's metastatic, but I am really curious, where does one start with reversing or avoiding inevitable resistance?
You start where you're at. So if you're already in a resistant state, there are things that we can do we can test your tumor. For instance, we can take a biopsy of the tumor and see if there are unusual or off the usual recipe or protocol drugs that your tumor might still be sensitive to. That's not often done in standard therapy, and the tests are not perfect. They're problematic in some ways, but at least they're, in my opinion, better than going to the list of drugs that have worked sometimes for a few people. And we're usually talking about a very few. We're talking about the single digit percentiles in terms of treatment efficacy for advanced cancer. So rather than doing that, we actually interrogate the tumor if we can. If a biopsy is safe, if there's an accessible site, if there's enough tissue for a live tissue biopsy. And we will test that live tumor against various drugs and combinations of drugs, even, and this is really quite heretical, but I have a colleague who will test these tumors against all sorts of normal chemotherapy drugs, cisplatin, Taxol, those kinds of things, and also against things like a metformin analog or ivermectin. And by the way, most tumors are not sensitive to ivermectin, but every now and then there is one. You mentioned a patient with prostate cancer, and frequently it usually is treated by blocking the male hormone until that treatment stops working. And again, it's expected that the treatment will stop working. My Moffitt colleagues and I, we've written a paper, we're hoping to publish it, on reversing androgen deprivation therapy resistance by giving testosterone to a patient with prostate cancer. That rescues some of the cells in the tumor that are sensitive to testosterone and allows them to repopulate the tumor. they actually are a little bit stronger than their treatment resistant brethren, because if you're a cancer cell, maintaining treatment resistance is a burden, like carrying an umbrella. People who are not having to carry an umbrella in a foot race will win. Moffitt Cancer Center is pioneering efforts in prostate cancer. They have some very brilliant theoreticians there who are working very hard to prevent and reverse treatment resistance. So I'm just fortunate to be able to tag along with some of my patients.
So it's really interesting because there's a lot of work happening in the breast cancer world as well about antiprogestins. We've been maybe going down a path with estrogen deprivation that is also not necessarily ideal. Sure,
Exactly.
for men, testosterone deprivation would also be not ideal. And I think you had said you've seen the adding testosterone work. Like it's not just theoretical. You've seen it work.
Oh, yes. This paper that we're publishing is a case where we've reversed resistance to androgen deprivation therapy, cutting off the testosterone in a patient whose prostate cancer had become resistant to that therapy. And the next step is usually really powerful chemotherapies and things like that. We were able to move him back along the time spectrum to a place where his tumor was still sensitive to the usual treatments. And then we pulse those treatments rather than giving them constantly. We actually use the patient's tumor dynamics. In other words, how fast the tumor grows if we withdraw treatment and how quickly it shrinks when we reapply treatment. We use that to develop dosing timing frameworks that maximally prevent resistance. We've also worked with breast cancer patients in an analogous way. Of course, breast cancer is related to female hormones, not male hormones. We've worked with patients giving female hormones in breaks from anti-female hormone therapy to toggle and manage the side effects from hormone deprivation, which are quite severe. That relieves a lot of the side effects and prolongs the sensitivity of the disease to treatment so that these patients have very long lives and very active, non-symptomatic lives.
I know I was going to ask this towards the end, but it just has to be asked now. How are you able to tell the dynamics of a tumor?
One of the most exciting, I think most oncologists now are using blood tests, liquid biopsies, circulating tumor DNA, not circulating tumor cells, but just the DNA, the nucleotides and nucleic acids from tumor cells in the body. We can use those to estimate the tumor burden, which is what we call the amount of cancer in a patient's body. And that number from a blood test, as tumors live and grow and die and replace themselves within your body, it's a dynamic process. We can measure whether that process is leading to tumor cell accumulation or tumor cell depletion by whether that number in your blood test of circulating tumor DNA is going up or down. And we can see how fast it's occurring as well by how fast it goes up or down. So I will use those tests once a month if I can. And I think one of the things that really got me thinking about this was the frustration that I and my patients and my colleagues felt at not knowing whether a treatment that we were offering a patient was doing anything for them. And the only way we would know, for instance, if a patient had benefit from what we call adjuvant or post-operative breast cancer therapy, for instance, was to give it to them whole course, 4 6 months, something like that, and then wait and do a scan every 3 6 12 months to see if the cancer came back. And that was the only way we could answer that question. I thought that's just not okay. We need to know in real time whether this treatment with its toxicities is actually doing anything beneficial. So prostate cancer cells make something called prostate specific antigen, or PSA, usually, not all of them, but most of them. And we can measure that in the blood. And if the number is going up, it means the cancer is growing. If it's going down, it means it's shrinking. And so that's one that's very nice to use. And that's one of the reasons why prostate cancer has been studied first using this particular paradigm, because there is a way to measure in real time how the patients are doing. Breast cancers, not as much. So about a third of breast cancers will make a tumor marker. You've heard of these CA15-3 or CA27-29, more rarely CEA or CA125, although those tend to be related more to gastrointestinal or gynecologic tumors, respectively. But if the patient has breast cancer and that breast cancer makes one of the tumor markers, then we can measure the tumor marker as it goes up and down, off and on treatment, respectively. So those are the tools that are used for mathematical modeling. To have that particular approach, we do have to have that kind of a tool available for that patient. But with circulating tumor DNA, it's becoming more and more available for almost everyone.
So one of actually my very first guest was Dr. Peter Kuhn down at USC, one of the leaders in liquid biopsy and looking at tumor cells as well as what they call oncotypes. It's very exciting where things are going with blood tests. I remember you using or talking about continuous glucose monitoring for something as well.
So continuous glucose monitoring is really separate from what we've just been discussing. So a lot of patients with cancer have metabolic derangements in their ability to use and process glucose to make energy. Tumors often will be very enamored of using glucose for energy. So if the patient's blood glucose is a little too high, or if it spikes after each meal, even if it's normal in between, that can set the tumor up to grow faster. So using a continuous glucose monitor, we can see throughout the day how a particular meal, how a particular activity, how much sleep or sleep loss will affect the glucose levels in the body in real time. And that's really important for patients who have problems with high blood sugar or even diabetes or prediabetes, because if you just look at a list of food out of a textbook or a magazine article, or even that your doctor's office gives you, eat this, don't eat that, that is only correct for large groups of people on average. I would argue everyone is not average. You are going to get different results with various foods that other people perhaps got. So there was an interesting study done about 10 years ago, showed that one particular pair had the exact opposite response to each food. So in one pair, the first person, when they ate a banana, their blood sugar was just perfect. When they ate a cookie, the blood sugar went way up. But the other person was the opposite. When they ate the banana, their blood sugar went way up. When they ate the cookie, nothing happened. So, which list of foods are you going to give those two subjects in that trial? So really, you have to look at your own blood sugar profile to know how your body responds to particular foods, meals, combinations, schedules, and it will change too. That's a powerful tool that people who have those kinds of issues and have tumors that are sensitive to glucose can use, and that's where a CGM is very powerful.
Let's talk about your N=1 research, your single patient trials, which seems to go against a lot of what we consider the gold standard, large double-blind control trials. Tell us more about why you believe that the N=1 is how you do it, and why you think that is where the future of medicine is going to go.
I certainly think it's the future of oncology. And the reason I think that is because simply large randomized controlled trials have failed in oncology completely. Over the past 40 or 50 years, 4 or 5 decades of large randomized controlled trials in the common cancers of adulthood in the metastatic stage. Okay, I'm not talking about stages 1, 2, or 3, but I'm talking about in the metastatic stage: breast cancer, lung cancer, colon cancer, pancreatic cancer, those kinds of, and a few others. Those kinds of cancers have not been cured despite decades of large randomized controlled trials. Completely failed. Not one cure. I think it's time to retire the large randomized controlled trial for many parts of cancer research. Of course, it still has a place, but I think the place is going to be smaller. We can have two people with the identical mutations within their cancer, and they may respond differently to the same treatment, because there are so many other variables that come into play and are active in a cancer situation. These are large systems. When you perturb them in one way, something else balloons out there, and you squeeze over here and something balloons out there.
Interrogating the tumor and testing the tumor's response to different treatments, and then what treatments does that tumor respond to?
So we can take the tumor out of the patient and test it outside of the patient. Is that perfect? No. The best test is the tumor inside of the patient. So, because the inside of the patient will differ from the inside of the next patient. Yes, it's very, very specific to that particular patient and to all sorts of variables that we don't think of. Time of day, time of day that they eat, how recently they've had any antibiotics, because that changes the gut microbiome, how many vaccinations they've had and which ones, how recently they've had COVID or flu. Those things all readjust the body's ability to fight cancer. And we're just starting to understand that.
So if a patient is re-engineering how they're living their lives, or at least being much more attuned to things like, okay, you need to track your sleep, you need to think about the times you eat, what the composition is, and all these things beyond what's happening in your office or an infusion center.
All of these things in my practice, we like to take a look at and adjust and optimize as best we can. And we try to measure to see whether we're meeting our goals. So, one of the things that I really try to do with my patients is not just, again, give them a list of rules or suggestions, get better sleep or get some exercise or have a healthy diet. I actually measure and help them measure. They don't need me to do this, but I like to be able to have them measure and see whether they're meeting their optimal sleep goals, amounts and stages and those kinds of things, whether their blood sugar is in a good place all day and all night. Are they actually getting enough exercise and the right kind of exercise? That's an interesting one because even very fit people who exercise a lot tend, and these are large randomized or at least observational studies, large trials look at even athletes tend to overestimate how much they actually work out and exercise and how intense it is. So actually seeing on your phone exactly how many steps you've taken that day, how many really intense zone 5 workouts you've had and how many minutes that week, how many zone 2 workouts, how much of that you've had, really is eye-opening to people and allows them to take control over something that they didn't really have a fuzzy sense of and really no control over. I haven't met anyone who doesn't like to feel like after a terrible diagnosis, like a cancer diagnosis where your life is threatened, having some more control is generally something that people thrive with and look forward to. It's
And
really empowering. There was actually a study in Canada, the START trial that you've probably heard of. I think it was finished about 10 years ago that showed that exercise actually did improve survival in patients who were on chemotherapy who exercised at a vigorous level 3 times a week for 40 minutes. That was the amount in the trial. And that's a lot for people, especially if they haven't been exercising. But it actually improved survival. So those patients who did their exercise during their chemotherapy, not waiting till after they're done, but actually during their chemotherapy, actually had better breast cancer specific survival, meaning that the exercise helped kill cancer cells. This is an anti-cancer medicine. Don't just go out and exercise and hope your cancer goes away. It's not going to. But if you are having treatment for cancer, you can talk to your own doctors about this study and say, does this apply to me? Should I be exercising 40 minutes 3 times a week? And maybe I should. And I think that's very empowering and really important for people to know exercise truly is medicine.
I just had a vision of a very specialized Peloton exercise support group. We're going to do a 40-minute or maybe an hour so we have time to warm up and cool down. A lot of times it's also just being connected to people. I was very lucky. I had been working out, lifting heavy weights, doing metabolic, high intensity interval training for years before I was diagnosed and didn't stop while I was diagnosed. It's great that it helps make the chemo work better. It also can reduce side effects. Like we have an episode with Dr. Jay Harness who's talking about exercise oncology.
People who exercise have a lower risk of cancer in the first place. If they do get cancer, they tend to survive. And if they start exercising during a treatment, even if they weren't exercising before, they have a better outcome, a better cancer specific outcome. Yes. And that's specifically about recurrence. So what that means, what is recurrence? Recurrence means that you didn't kill all the cancer cells the first time around with your treatment. There were still some there. So the exercise, yes, is part of the treatment.
I'd love to know how you came to this work, how you chose oncology, how you chose medicine, and then how you came to this work, the work of challenging the conventional thinking and doing this level of personalized medicine.
I secretly am a hypochondriac and wanted to be able to have more say in my own health. But I was interested in medicine and cancer from a very young age, like 7 or 8. And so I also was very interested in nutrition and how lifestyle and exercise played into whether people got cancer, whether they recovered. I have a master's degree in epidemiology because that was the only way when I was in college that you could study cancer and nutrition and cancer and exercise by looking at large groups. Now we have more tools, and so we can look at the individual. So one of the reasons that I've become interested in the individual is because of the maturation of some of these tools that allow us to look at the individual. So in the past, I'm not faulting past medicine. Those were the tools we had. We had epidemiology. We can look at large groups of people, or we can try to look at large groups of people. It turns out that's not a very great lens, but we can look with the tools of epidemiology. Now we can look at each person separately. I also have been very interested in large complex systems and the mathematics of large complex systems. And I'm interested in development, biological development. And cancer is development gone awry. Why does an egg and a sperm united turn into a whole organism with many parts and organs and senses and things like that? And of course, cancer is a problem of that particular process. So those are some of the things that got me interested in this particular field. I wake up every day thinking I'm so lucky that I get to be a doctor. That's what I've always wanted to do, to get up in the morning and get to do this work.
There was this term you've used in the past called mathematical oncologists, which kind of sounds like something from a science fiction movie. What is mathematical oncology, and how are you using math? And how do you think AI, which is math on steroids, how are you using math?
I'm waiting for the math-based AI models to come out. Right now we have the word-based ones, and they're pretty fun, but wait till the math-based ones come out. There's a department of, there's an integrated mathematical oncology department at Moffitt Cancer Center, and people who are interested can go to the integrated mathematical oncology department of Moffitt Cancer Center website and kind of look around there and see what they do specifically. But basically, it's using mathematics, which is the language of nature. Mathematics and nature are the same, to predict treatment response and growth patterns and all sorts of parameters related to cancer growth and shrinkage. One of the most sexy parts of that is something called game theory, where you can take two agents that have a particular goal and give them some simple rules and set them against each other and see who prevails. For instance, how that would work in oncology is when a tumor becomes resistant to a treatment, it generally upregulates a certain pathway that will negate the effects of the treatment, either by changing the drug's chemistry or by having the cell be able to spit the drug out, or by making it so that the cell no longer takes up that drug, or any kind of mechanism. One of the things that the game theorists in the Department of Mathematical Oncology, or the field of that mathematical oncology, try to do is figure out how to set up a series of drugs so that as the tumor becomes resistant to one, it becomes sensitive to the next treatment that's going to be applied. So that's a double bind. So yeah, tumor cell, you might go ahead and figure out how to make your cell surface not fit this drug number one, but if you change it in a way so that it then fits number two, then we're coming in with number two. And we try to engineer that. That's one kind of approach. One of the things that we do with, say, prostate cancer is look at how fast the tumor goes up, the PSA goes up, and how fast it comes down with a particular treatment. And we try to, instead of making the PSA go down, figure this out except by watching what the tumors do. It turns out that if you just make the PSA go down a little bit, like maybe 50%, and kind of keep it between 25 and 75%, you can make the sensitivity last a long time. And you do that by withdrawing and reapplying the treatment as needed to keep the PSA within those parameters. And one of the things that we're taught in classical cancer school is get that tumor marker down as far as you possibly can. It turns out that's the worst thing you could do. If you want to create resistance, that's how you do it. And we were taught that no, if you want to prevent resistance, you get that tumor marker down as long as you can, and you keep hammering with that same drug. And what we would see is that even when we did that, the tumor would eventually escape and come back up, even though we were still hammering with the drug. That's another place where mathematical oncology has been helpful. There are in silico models that mathematicians can make of tumor growth, and then they can test 2 or 3 parameters. Some of the people doing this at Moffitt have found, for instance, that applying certain drugs at certain points in a tumor's growth cycle, like bevacizumab, which is an anti-angiogenesis agent, can actually make the tumors more aggressive. Or they can prevent, because they block the production of blood vessels. If you give that first and the tumor's blood vessels shrink away, then you give some chemo, the chemo can't get to the tumor. So the chemo's been rendered ineffective. So all of those things were discovered and thought about and tested in animal models, first tested in silico, looking at computer screens and what's going to happen with this, tested in animal models and types of mathematics that can be used to inform cancer treatment and also to give us more understanding of how cancers act and grow in a 3-dimensional system.
I can imagine a future where a patient's getting treatment and blood's being tested, maybe they're scanning, but the actual infusion is being almost controlled by computer and changing based on what these models predict, and then seeing how the tumor responds in the body. The
Yes.
simplest, Dr. Esserman says, all that matters is if it responds to treatment. And you happen to have a pathology that we think is going to be very responsive to treatment, but that's what matters. And it was a really different mindset. And it actually shaped how I approached every infusion. I didn't have the anxiety. I was, okay, my tumor is going to be obliterated. I have a tumor that is responsive to treatment. Let's see how responsive it's going to be today. But I can imagine the levels of granularity, of fine tuning that, and the people who come after you are going to be able to do are going to be mind blowing.
We will have patches on the arm that are like continuous glucose monitors, that'll be continuous tumor monitors. Yes. And whether the medication's taken by mouth or by patches on the skin or by infusion, which I think will be an old-fashioned way of delivering medication in another couple of years, we can adjust the treatment in real time rather than 3 or 4 or 6 months down the road at your next scan.
Number one, if you could choose only one biomarker, but you're allowed to track it as much as you want to predict treatment resistance, what biomarker would you choose?
To predict treatment resistance. So it wouldn't be the biomarker specifically, it would be the change in the biomarker. It doesn't matter what the biomarker is, it's how it's changing. That's what's important.
Awesome. Okay, so we don't care about the one, we care about the change, delta. All right.
Yes.
What is the most dangerous assumption standard oncology makes about metastatic cancer?
That treatment should be maximal and continuous. And that is a recipe for resistance development. That is how you create resistance in an ecosystem.
It's interesting because I think we've all become aware of that with antibiotics, right? We know that
yes, herbicides and pesticides in agriculture, in any place that you look at large systems, if you try to eradicate one particular element, you will run into this biological system, you will run into this particular dynamic.
There's something to this evolution concept. Speaking of evolution, what is one thing you wish every oncologist would understand about evolutionary biology?
Again, it's the same thing, that cancers change and we should try to steer that change rather than just accept it, follow it, and chase it until the patient dies. So we want to get in front of it. We want to play, one of my colleagues at Moffitt says, we want to play chess with cancer, not whack-a-mole.
That makes sense. All right. What's the biggest misconception patients have about metastatic cancer?
Again, I think the idea that maximal treatment and pushing the tumor markers and the scans to NED or no apparent disease, no evidence of disease, is beneficial. And often that is counterintuitively, that is the worst thing you can do in terms of long-term survival. You want to figure out how to manage the cancer. And if you push it down to near oblivion, what you've done is left the worst of the cancer cells to survive, repopulate, and finish the job.
Yeah, survival of the fittest, right? You've killed off all the weaker ones, and what's going to come back is the treatment resistant strain.
It's not survival of the strongest or its fittest. And that's the fitness has to do the cancer cells that survive may not be that fit. In fact, they aren't. They're carrying these umbrellas around. And when it's not raining, they're not as fit because they have to carry the resistance machinery around. But they are able to survive the chemotherapy. And whether they're stronger or weaker than their treatment sensitive brethren really doesn't matter. But certainly it doesn't mean that they're stronger. It just means that they have survived that particular drug.
Okay, thank you for the correction. All right, and if mathematical oncology becomes mainstream and these models are widely available, what do you think changes first?
What will happen is that these cancers that were universally fatal, people will live with them for a long time. And the semi-truth that your cancer is not curable, but it's treatable, which I think right now is a bit misleading because I think it makes people think it's like high blood pressure or diabetes. So the idea that it's treatable but not curable, I think is not true right now, but I think it will become true. So as long as we are able to skillfully use the same drugs, what's beautiful about this is that we don't have to even find necessarily, there's nothing wrong with finding new drugs, but new drugs, if they're used in the same old way, aren't going to answer the problem of drug resistance. Even the new drugs we have, they all have the same problem of resistance development. So the first thing that will happen when these paradigms are used is that metastatic cancer will become a truly, if not cured, a truly treatable condition that patients can live with for decades.
That'd be amazing and a lot less scary for everyone. So I love the role you're playing in kicking cancer's ass. The curiosity, the science, the innovation, the willingness to think outside the box. It's really inspiring.
My focus is on figuring out what works and how to get it to work in the patient in front of me. But I think that's something that patients have been becoming activists. And I think this began back with HIV. I remember patient activism really taking off then. And with breast cancer, it may have started even before then. And I think the patients are the ones that need to be and want to be and should be in control of doctors and what we study and how we study it. And I think that's how this will become available to everyone. Patients will say, we need this.
So if a patient walked into your office and was advocating, like that's the patient, you want that partner, that person who's coming in with questions and wants to understand and challenge. Is that because people don't want to be
Absolutely.
disrespectful to a doctor, right? They're your doctors, we're not.
I think that that's long gone. And I think that people are better educated now and they do have access to a lot of information. There does need to be some curation. Oncologists are going to be better at that than a person off the street who hasn't thought about cancer ever and now suddenly has to think about it because they've got this diagnosis. There's 10, 20, 30 years of thinking before that. You're going to get a higher quality of thinking about the situation. So please go and see an oncologist if you have cancer, a real oncologist. But yes, do your own research and homework. Be willing to do the work. So no doctor is going to go to the gym with you or measure your heart rate variability, or some of them might prescribe you a CGM, but in a lot of states now you can go get your own. And you definitely want to be active. If you're going to be an activist, be active first in your own healthcare. Keep your own records. Get the records from your doctors. Every time you see an oncologist, you get a little summary in the electronic health record. These are your pills and your next visit is blah, blah. That's not the real medical record, okay? The real medical record you have to go ask for. And the doctor writes up a note. This is what I saw. This was a physical exam. This was how our discussion went. And the patient seemed to understand it or not understand it and decided to take my advice or decided not to. That's the real record that you want. And please get those, keep them, and show them to all of your doctors so that they all have a picture of what's going on with you.
That's great advice. I think for any appointment with your doctor, by having the data and asking pointed questions, it served me very well. It seems to have served all the different survivors I've talked to. And as the patient, you're the quarterback. It's your life.
I think patients need to understand that the doctor is not really in charge. I mean, they are in a certain sense, but not as much as you are and not as much as you should be. Unless that's some patients do have the, hey, this is overwhelming, just tell me what to do and I'll do it. That's a particular stance. I think that that's less common now. And it depends on how sick you are too, whether you have the energy to look into things. If you don't, then get a relative or friend to help you with that, to advocate for you. But yes, I think if at all possible, you want to be the one in control. And usually cancer is not an ambulance calling emergency. You have some time to gather information and figure out what seems to be the best course for you.
And I think people forget that there's time. There's even time during treatment. There's time. And there's opportunities to learn. Dr. Lemanne, you've been very generous with your time. If our listeners want to dig deeper into your approach, into being their own best advocate, whether they're patients, caregivers, or even other healthcare providers, where can they learn more about the work you're doing and learn more about the N=1, mathematical oncology, understanding the right markers and looking for the right change? I would love your list of suggestions.
Sure. So anybody is welcome to look at my website, then take a look around. There's a course coming up that I'm giving on using personal health monitors like wearables like CGMs and heart rate variability trackers, fitness trackers, those kinds of things. If you're interested in that, I think there's going to be a URL up on your website as well for that. And people are welcome to get in touch with me. I even answer the phone.
Fantastic. Thank you so much. Another episode of Kicking Cancer's Ass with all kinds of innovation and thoughts from the wonderful Dr. Dawn Lemanne. Thank you for being here.